that might be wanting to join. So just give it a couple more minutes and we'll see who else might join us now. Won't be long, guys, and we'll be right with you all. I'd like to start anyway by welcoming everyone to tonight's webinar for Ready, Set, Baby. This is a great program and it's always fantastic to have these guest speakers and presenters answering all kinds of questions for us. And by the way, my name is Julie and I'll be your host this evening. I'd like to start by acknowledging, in the spirit of reconciliation. So the acknowledgement of country, in the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I'm Dr. Julie Becerra. In case you don't know me, I'm from the Fertility Pod. We've been working with Monash IVF for the last 16 years and very proud of the work that we do. I am a leader of, I do practice Chinese medicine. I've been helping women and couples conceive for a very long time. And I have a fantastic team. We really specialize in supporting patients and with a huge focus on research into nutrition, lifestyle, hormonal health, autoimmune factors, etc. So very, very happy to be here. And also I've contributed a lot to the Ready, Set, Baby program. So I'm very happy to be hosting for you tonight. So Fertility Pod was founded in 2010 and it's one of Australia's first clinics to bring natural and traditional fertility care together. I'm known as a bit of a pioneer in collaborating with Western medicine, along with the gynecologists and IVF specialists. And, you know, it's fantastic the work that we've done together, Monash IVF and ourselves, to bring that collaboration and to help patients through diet, lifestyle, and just to improve their well-being for IVF. About Monash IVF. So Monash IVF, like I was just saying, has a great focus on natural health and preparation for becoming pregnant. They're committed to empowering the next generation of parents on their journey to parenthood. They are here for people at all stages of their fertility journey and support patients of all genders, family dynamics, and sexualities on their pathway to parenthood. The entire Monash IVF team are incredibly passionate about the care and support they provide their patients. Monash IVF provides world-leading scientific and medical services, and there are clinics across Australia in Victoria, New South Wales, Queensland, Western Australia, and also our Repromed sister clinics in Northern Territory and South Australia. And here are the services that Monash IVF, if anyone's interested, these are the services that they offer. They provide comprehensive reproductive care. They offer everything from fertility testing through to IVF, IUI, and ICSI. And of course, they can support a variety of donor treatment options also. So here's a quick look at tonight's agenda. So we've got a great panel this evening. So after the introduction, we'll move on and we'll get to hear Dr. Anju Agarwal running through debunking fertility myths. And I'm sure that anyone that's been on this journey for 2 seconds or for a very long time will know that there are a lot of confusing, there's lots of confusing information out there. So debunking myths is fabulous. We also have Dr. Jenny Cook running through preconception health tips, stuff that you can do for yourself to prepare and help you to get pregnant. Dr. Kelvin Larwood is running us through factors that are impacting fertility. So I'll be introducing you to the panelists in just a moment. Everyone on the panel will be sticking around for a little while at the end of the presentation to answer your questions. So please submit your questions for the Q&A using the Q&A button at the bottom of your screen. So there's no such thing as silly questions. They're all anonymous and nobody else can see them. So please do feel free to take the opportunity to ask away. We will do our best to answer your questions, but if we can't get to them all, it's important to us that you get the information that you need. So if your question isn't answered, we will offer a complimentary phone chat, and our team of experienced fertility nurses will be there to assist you. The nurse inquiry team can provide you with advice about what your next steps could be and answer any questions you may have about fertility or fertility treatment. You can scan this QR code on the screen and book a complimentary nurse chat. A nurse team can also help you book an appointment with one of our doctors if you wish. And I'd just like to do the disclaimer. Whilst we do our best to be affirming, we just wanted to mention that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We are proud to support patients of all genders and sexualities. Everyone is welcome in our clinics. The information provided in this webinar is general in nature and does not replace personalised advice from medical practitioners. So, like I said, we've got some wonderful presenters tonight, and I'd like to introduce Dr. Anju Agarwal. She'll be our first presenter this evening. Dr. Anju is a gynecologist and fertility specialist consulting out of Bendigo. She has over 15 years' experience in obstetrics and gynecology in both Australia and overseas, and holds fellowship with RANZOCOG and has a Master's of Reproductive Medicine, and has a special interest in laparoscopic surgery and fertility care. She's known, and I have to back this up, for her warm, honest, and patient-centered approach, and it's wonderful to have her here tonight to present on debunking fertility myths. Our second presenter will be Jenny Cook. So Jenny is a gynecologist, fertility specialist, advanced laparoscopic surgeon, and the clinical director for Monash IVF in Bondi Junction. She's got over 20 years of experience in gynecology and fertility, which if that wasn't impressive enough in its own right, she's also an examiner for the College of Obstetricians and Gynecologists, where she's been examining for over 10 years. Her special interests lie in the field of fertility treatment, endometriosis, fibroids, hysteroscopic surgery, and she's been published in numerous medical journals and even asked to speak internationally due to her expertise. It's a pleasure to have Dr. Cook presenting on preconception nutrition tips for us tonight. Welcome, Dr. Cook. And finally, our final presenter will be Kelvin Larwood. Kelvin is a fertility specialist, obstetrician, and gynecologist at Monash IVF Sunshine Coast, holding a fellowship with also obstetrics and gynecology, and originally trained as an intensive care nurse before studying medicine. He carries over 10 years' experience as a specialist caring for individuals and families across all stages. Kelvin specialises in infertility with a particular interest in laparoscopic and pelvic gynecological surgery, pelvic pain, and abnormal periods. It's a pleasure to have Dr. Larwood here to run us through factors impacting fertility. But first, I would like to welcome Dr. Anju for our first presentation of the evening. And thank you, Anju, for joining us.
Hello, everyone. Thank you for joining us this evening. I'm going to talk about fertility myths and aim to debunk some of them. So, is it true or false? Women are born with all the eggs that they will ever have. I wish I could have a button to get a vote over here, but the answer is true. All women are born with the number of eggs that they will ever have. So women are born with finite number of eggs, and as they go on with their lives, as the periods start, they start depleting them. In fact, when they have the first period, they almost have 400,000 eggs left. And in every cycle, women lose about hundreds of eggs each time, with one follicle becoming a mature follicle. And the number of eggs continue to decline until menopause. And this decline of egg is called the egg reserve, which rapidly declines after 35, which is why 35 is the magic number. And as women age, not just the number, but the egg quality of these eggs also decline, which is why it's a challenge for women to conceive as they get older. So the next one, if you have sex every day, you're bound to fall pregnant. And that, don't listen to your neighbor. It's not true. You are not going to get pregnant if you have sex every day. This is because the volume of sperm in the ejaculate, it decreases with frequent ejaculation. So sex twice a day is not helpful. It's important to give time for the sperm to replenish. So conceiving or every second day, I almost say conceiving every 36 hours, like the night and the 24 hours later in the morning, is kind of useful in the fertile window. So 36 to 48 hours is a great time, the spacing. The chance of conceiving each month is quite high. It is true. So the longer we try month after month, the chances that a person will fall pregnant. Um, in every month, there is an approximately 20% chance of conception. As the women age, though, this chance or the possibility of pregnancy declines. Um, this is why we suggest that a person should try for 12 months when they are younger, or 6 months as they get older before they seek help from a fertility specialist. This doesn't mean that everyone needs IVF treatment, but it just means that it's an important time to ensure that everything is working well for them and there is nothing obvious that needs to be picked up. And then timing of unprotected sex should be around the time of ovulation to get them the best chance to conceive. Chances of success also depend on the unique medical conditions, like if women have background polycystic ovarian syndrome or have had history of chlamydia or any other condition, that is important that they seek help earlier. If you have diagnosed with PCOS, it means you will need IVF to conceive. This is definitely false. All women with polycystic ovarian syndrome will have the desired number of children in their life. That said, some women do need help to conceive, not necessarily IVF. So statistics say 60% of women with PCOS will conceive naturally without any fertility clinic intervention, in fact. They behave differently. Some will have irregular periods. Some will not be ovulating. Some are overweight. Some may have pre-existing diabetes. So what do we do in a clinic that is outside IVF? Some women who have delayed cycles, all they need is to help with timing of their ovulation. Because it's really difficult when they have long cycles as to when you're ovulating and when is the right time to have sex. So all we can do is ovulation tracking and narrow down the period for when people need to have, so to say, timed intercourse. Some people are not ovulating and they might need help through oral medications to actually start ovulating. And then others may just need lifestyle changes to help achieve natural ovulation. Lifting your legs up in the air after having sex will help you fall pregnant. I love this one. The answer is no. Are chemically programmed to travel where they need to go. There's no harm in doing this if you want to, but it doesn't help you fall pregnant faster. Remember, women can get pregnant standing and having sex as well. So no, it doesn't help. If you don't have a period pain or pain with intercourse, you can't have endometriosis. That is false. We see often in our fertility clinics that infertility itself can often be the first sign of endometriosis. The symptoms vary between women and women. Whilst period pain and pain during intercourse is quite obviously endometriosis type symptoms, but women don't know about endometriosis and come to us with fertility or infertility only. 30% of the women who have infertility actually have underlying endometriosis, and it is sometimes the only sign. And the severity of endometriosis does not necessarily indicate or go hand in hand with the symptoms. And as I said earlier, the delay in getting pregnant or infertility may be the only presenting symptom for these women. Approximately 1 in 4 pregnancies end in a pregnancy loss. Sadly, this is true. It is quite devastating when this happens, and this is a common complication of early pregnancy. There are lots of support groups available should this happen to you, like SANS Australia, which is a great community and support resource. But if a woman has experienced 2 or more pregnancy loss, and this is now called recurrent pregnancy loss, thanks to the change in the new guidelines. And if you are experiencing recurrent loss, please see a fertility specialist for support and fertility investigations, because there are lots of things that can be investigated and done to help. As women get older, though, the risk of miscarriages increases. The more common cause of miscarriage is chromosomal abnormalities, and it's nothing to do with you or your body or something you've done, which is what women tend to think first. And then that is why it's very important to see somebody, get advice, and understand why this is happening. But definitely the incidence of miscarriages increase as women get older, and there can be help available to you. Trying to conceive after a pregnancy loss can be challenging. For some people, they may need time to heal and reach out for emotional support. But it's very important to know that there is no gap that is necessary. A lot of people do tend to think that once you've had a pregnancy loss, they need to wait for a few months, and that is not true. Once they've had a period, they could start to try again. If you have a low AMH, you have low fertility. This is absolutely not true. The AMH is not a test of fertility. It is just a test of number. AMH does not measure the quality of eggs. It's just it's a finding to indicate what the egg reserve is, so people can be proactive about their approach to fertility. It helps with pregnancy planning for those who are not ready to conceive at the time, in terms of egg freezing or embryo freezing. And for those who are thinking about falling pregnant but are considering their options, it helps to direct them in the right way, whether IVF is for them or whether some other treatment is for them. Often it is also a marker that helps clinicians to direct what dose of medications they're going to use, but it is definitely not related to their fertility or the quality of eggs. There are other tests available that can help assess the fertility, which include pelvic ultrasound, tubal patency test, SIP analysis for partner, and so many more tests that are available. It's also very important to understand that when women get older, the AMH and the egg quality is very important when we are assessing a woman's fertility. I always say a 40-year-old with a low AMH and a 40-year-old with a high AMH are very different patients, and they needed to be treated in a whole different manner. So a high AMH in a 40-year-old is a very reassuring sign, whereas the low AMH is not. And again, the egg quality could be different and AMH is different, and therefore it's not a measure of infertility. If you've had your first child really easily, you will have no problem falling pregnant with your second. This is absolutely not true. Secondary infertility is quite devastating when it happens, because a lot of people believe that when they've had no problem conceiving their first, it should be quite smooth, straightforward, but often that is not the case. Secondary infertility is very common, and a frustrating thing for a lot of people is that often they don't know why. And that is when we tend to, uncover lots of underlying conditions, for example, endometriosis and PCOS, where, in some cycles women ovulate. There are a lot of women who put on weight when they have children. So then it becomes that they're not ovulating after the second birth, and so many more reasons why there are issues conceiving the second child. And the same rules apply, that if you've been trying and not falling pregnant, then you need to see your fertility specialist sooner rather than later. Again, if you had complications during your birth, which also may impact infertility, multiple miscarriages, all of those reasons, you need to see a specialist. And if there are obviously fertility issues that has been identified by your GP, then definitely seek help. Thank you. Feel free to contact us here if there is any help needed. And I think we will have our next presenter, Dr. Cook, presenting on preconception health tips.
Good evening, everyone, and thank you so much for joining us. I am going to be talking a little bit about preconception health tips. So broadly speaking, I will be covering the reproductive systems of male and female, and then moving on to some preconception health tips. So this is the female reproductive system. This is something that I suppose I work with every day, and I'm constantly showing women this particular model. The vagina is obviously at the bottom of the screen there, and that's the passage that connects the vulva to the cervix. The cervix, we say, is the neck of the womb, and as far as fertility goes, it produces this mucus. It's like this egg white mucus that you can see in the middle of the month around the time of ovulation, and that's what helps the sperm to travel up through the uterus and into the fallopian tubes. The uterus has a lining called the endometrium, which thickens under the influence of estrogen to support the embryo. The ovary, you can see, is that circular white structure that releases, that's where all the immature eggs are sitting. That releases a mature egg on a monthly basis, or if there might be situations where it's irregularly released, such as with polycystic ovaries. And the process of maturing the egg, the estrogen goes up, and then when the egg is released, then progesterone is produced, and that all acts on the lining of the uterus. The fallopian tube picks up the egg. In fact, we don't know what that mechanism is for the tube to pick up the egg. There's gentle, it's like a peristaltic action that the egg travels along the fallopian tube. When the egg is released, the sperm is actually sitting there lining the tube that surrounds the egg in the outer 1/3 of the fallopian tube, and then the embryo is carried down into the uterus and it implants in the endometrium. So ovulation is the process where the body releases a mature egg from the ovary. It typically takes place 14 days before your next period. That's what we call the luteal phase. The few days, ovulation takes place probably over 24 hours, and that's obviously the most fertile time of your cycle. It's controlled by a finely tuned hormonal system, which in fact starts in the brain in an area called the hypothalamus, that drives the pituitary, that drives the ovary to produce estrogen. And as I've said before, the estrogen acts on the lining of the uterus to build it up. We say an adequate endometrial thickness for an embryo to implant is 7 millimeters. Once ovulation occurs, the progesterone starts to leak out, and implantation might take place something like about 6 or 7 days, something like that, after ovulation happens, and the progesterone is already there. In fact, we've done this out of order. The LH, or the luteinizing hormone, is released from the pituitary, and there's a sudden surge in that hormone in the 36 hours before ovulation, and that's the trigger for the final maturation of the egg and for the egg to be released by the ovary and then picked up by the tube. Understanding ovulation obviously will help you identify your fertile window. There's various signs of ovulation. The most common one that women would use is just being aware of clear mid-cycle mucus, probably in the 48 hours before ovulation. The sperm can survive for about 5 days in the female genital tract, but the egg's got 24 hours. So the sperm needs to be there beforehand. So we say if you had sex 5 days before you ovulate, you could conceive. Obviously, we encourage closer to the time, but in fact, you could do it at 5 days before ovulation, 3 days before ovulation, maybe 1 day before ovulation, perhaps the day of ovulation. And that's what we refer to as the fertile window. Okay, so this is the male reproductive system. We start at the bottom. The testicle is what the structure that produces the sperm and testosterone, and there's lots of what we call seminiferous, the tubules, that they're sitting in the testes. The sperm is produced, and then they are stored in the epididymis, which is the blue one, just sitting on the top of the testes. From there, it goes up the vas deferens. We call that the ejaculatory pathway, and then various fluids are added in. So the seminal vesicles will add in nutrient-rich fluid. It's rich in antioxidants. The prostate has a role to play as well in secreting protective fluid. And then finally it goes out, the penis delivers the sperm into the female reproductive tract during intercourse. So what impacts sperm production and quality? We would actually say it takes one sperm about, we've got here 60 to 70 days, but I'd probably say 90 days and 3 months. So that means that any change you make, a man makes in lifestyle, is going to have an impact on the future sperm. And any impact you make, it might take 3 months to see that result. So in simple terms, free radicals, heat, illness, I suppose toxins are free radicals, or stress can have a negative impact. But what is important is what can support sperm quality. Probably the most important, well, one of the important things is going to be antioxidants. And I would always get men to take Menavit, which is like the male equivalent of Elevit. Coenzyme Q10, there's a lot of antioxidants in green vegetables, so your diet is very important, and a handful of walnuts per day. We say moderate exercise, and I'll keep coming back to that. Over-exercising is bad, and under-exercising is bad. Everything is the happy medium, so just moderate exercise. We say to avoid overheating, so from saunas, spas, laptops. In fact, there's evidence that you should carry your mobile phone like Harry High Pants on your belt and not in your pocket. And clearly not minimizing smoking, but no smoking, no vaping, no recreational drugs. And I would say to minimize alcohol consumption. So your overall health can certainly influence fertility. And that's the importance of preconception care, to identify potential challenges and to address them. Preparing your body, and so that's got a knock-on effect. Preparing your body can help with embryo development, and this really applies to everyone involved in the fertility journey. So when you go to see a fertility specialist about to assess your fertility, what are some of the tests that they might organise? Well, cervical screening, so a pap smear if it's due. This is all just part of basic gynecological health. We might do infection screening, such as looking for chlamydia or gonorrhea. That's part of routine screening. I suppose we don't pick it up that often, but it certainly is picked up. Chlamydia and gonorrhea are known to in particular damage the fallopian tubes, and early detection and treatment can obviously prevent long-term issues, including pain and fertility issues. Blood tests, I think we've mentioned a couple of them. We've mentioned the AMH, which is a measure of ovarian reserve. We would do FSH and LH. FSH done in the first part of the cycle, and that's a measure of egg quality. A very elevated FSH is a sign of poor egg quality. We would ideally want it to be less than 12. There's a whole heap of blood tests we do. I've got prolactin there. Prolactin, at high levels of prolactin can have, it's the breastfeeding hormone, but in a prolactinoma, which is a pituitary tumor, women can end up with excessive levels, and that can have an impact on ovulation. In fact, some women would be amenorrheic. We would do iron studies, and if the iron stores are low, we can give supplements and check the vitamin D and give supplements if that's low. And the other things will be to check the thyroid. to do all the antenatal screening to look for immunity to rubella and chickenpox, and recommend vaccinations if there's no immunity. Hepatitis B, hepatitis C, HIV, syphilis. I would check for exposure to CMV. Not everyone does. And the other one for men is to look at a semen analysis. And the three parameters that we look at are the count, the concentration or the number, the motility or how rapidly they're moving. I should probably give you the normal range. The count should be about 16 million per mil. That's the World Health Organization criteria. The motility is roughly about 33% have progressive motility. The morphology refers to the shape of the sperm. So when a scientist actually looks under the microscope, what is the percentage that are normal? It is normal for 4% to be normal and for 96% to be abnormal. And we see the rate of spontaneous fertilization dropping off when that falls below 4%. So supplements, the main thing to take is folate, about 300 milligrams per day, and you could just go to the chemist, and it's in various different forms. There are some situations where we would recommend 500 milligrams a day, but for most women they don't need that. That's known to reduce the risk of neural tube defects, such as spina bifida would be one of the most common ones we see. Iodine is to support the development of the baby's nervous system, particularly those with thyroid disease. They should be taking an iodine supplement, and during pregnancy. Vitamin D, you'll see down there, there's limited evidence to suggest daily supplementation, but many women in Australia actually are vitamin D deficient because we go outside, we put on hats, we wear sunscreen. It has got a role to play in the later stages of pregnancy to facilitate the transfer of calcium to the baby. So we would say just check the level and take a supplement if you are low, if necessary. So what are the lifestyle foundations? Everything in moderation. So moderate exercise. Too much exercise is a bad thing. The ovaries can switch off, and in fact, too much exercise can have a negative impact on sperm production as well. Exercise is good to improve your metabolic health, to achieve an ideal weight, and for many women, if women are overweight, achieving a weight in the normal range can achieve regular menstrual cycles as well. So that's the importance of a healthy BMI. A healthy BMI would just set you up for a safer, healthier pregnancy with a lower risk of high blood pressure and diabetes. Having your weight in the normal range. So a BMI refers to a weight to height ratio, and in fact it's weight over height squared is what it is, and it should be about 20 to 25. Sleep and stress management is important, just because stress is a bad thing. We've not got any scientific evidence to say that the impact of stress on fertility, but just logically looking at it, stress is a bad thing. It's got to do with regulating all the hormones involved in ovulation and sperm production. I can't stress enough the importance of adequate sleep and a balanced eating pattern. I always recommend the Mediterranean diet, which is high in protein and low in overprocessed carbohydrates, generally, and also high in the good fats. So it generally, the fish, a deep sea fish, is the form of protein in the Mediterranean diet. And what to minimize or avoid, it doesn't come as a surprise. I ask every single person about smoking and alcohol. No, you have to stop smoking. Smoking will damage the DNA in both sperm and eggs. It's associated with low egg count, poorer egg quality, earlier menopause. Stop smoking. And I think vaping is worse. because vaping is just something that you do constantly during the day, and I think there's probably even more toxins in vapes. Our college says that there is no safe amount of alcohol to consume. So in fact, our college recommends no alcohol. Clearly, no recreational drugs. Again, because it can impair sperm and egg development. And caffeine, look, I would say try and limit it to 2 a day. I recall that you can take up to 4 a day when you're pregnant, but my general advice would be no more than 2 a day for many reasons, quite apart from the fact that it can increase anxiety and sleep disruption, which again have a knock-on effect to fertility-related hormones. And the pelvic floor is something that we should also think about as well in women who are planning pregnancy. It's the group of muscles at the base of the pelvis, which are important to support the pelvic organs, the uterus, the bladder, the bowel. They will have an important role in continence, both fecal continence and urine continence. They have an important role to play in sexual function. And pelvic floor exercises with a trained physiotherapist is absolutely vital to maintain their strength afterwards, to assist with the recovery following birth as well. We've got there, it can reduce the risk of pelvic pain. There would be women who have overactive pelvic floor muscles, which that is a well-recognized cause of pelvic pain. Just having adequate pelvic floor tone is important, and as I've said, it can support labor and assist with a better postpartum recovery. Exercise and fertility, again, everything in moderation. Exercise in moderation so that a woman is still menstruating on a regular basis. Her weight range is in the normal range, as I've said, BMI 20 to 25. Any exercise is better than none. Certainly don't start an exercise regime that is overly ambitious. Just start with something that is achievable, and just 30 minutes of physical activity per day. Try and work it into your day somehow. Use every opportunity, like, trying to get you 10,000 steps in is what it's about. Perhaps occasionally walk upstairs instead of getting the lift. If you sit at a desk a lot of the day, make an effort to get up and walk around, maybe on an hourly basis. It's good for stress. It's good for reducing your insulin resistance. A bit of exercise is just a good thing. Okay, so these are actually the general benefits of long-term exercise. This is something I didn't know. It can extend your lifespan by 6 to 7 years. And I think that's a knock-on effect from the fact that it would be associated with having a BMI in the normal range, it will lower your cholesterol, lower your fasting insulin resistance, lower your blood pressure. And exercise, when you exercise, you just feel better. It's thought to be that adrenaline rush. So it can decrease the incidence of anxiety and depression. Weight-bearing exercise is important for bone density. And as I've said, it can have a knock-on effect for lowering insulin resistance, maintaining your blood sugar in the normal range, and just ensuring that your weight is in the normal range, the normal BMI range. So thank you so much for your attention tonight. I, in fact, consult at many different places. My main home is Bondi Junction, but I also consult in the Sydney CBD in Cogra, and I've actually just started consulting at the Bodney Road Doctors as well. So thank you so much for your attention. I look forward to your questions later on. And now we're going to be hearing from Dr. Kelvin Larwood.
Thanks, Jenny. I hope you can hear me, and good evening to everyone. Thank you for joining us. I'm going to be talking about factors affecting fertility. So these factors are important for the egg provider, sperm provider, and person who's going to be carrying the pregnancy. The things that we look at and take notice of is the age of the person, lifestyle factors, their genetic history and family history, and also certain fertility conditions that can impact your fertility. So this is a 101 in many regards, but it's not surprising that we need to have eggs, which we've already been talking about, sperm, which we've mentioned, the uterus, which is an important organ in the female body to carry the pregnancy during the 9 months of gestation. And we need to consider, what resources are available to us. What do you have? What are you willing to use? And what do you need? So we're looking at what things that could indicate potential fertility issues. Previous pregnancies, a history is a really important part, and your past history has a big factor on how we would go forward. The age for both men and particularly for women is important. Your menstrual cycle, just how regular it might be, whether there's painful periods or heavy periods can have an impact. And symptoms that are known to be associated with fertility, like endometriosis and polycystic ovarian syndrome. We've mentioned before screening for infections, and some of these pelvic infections can affect the pelvic anatomy, and in particular the fallopian tubes. So that's why we want to test for that. For men, a history of undescended testes, infection or injury can affect the sperm counts and sperm production that then would have an impact on conceiving. Then the general genetics and medical history, and what medical treatments have happened to you currently or in the past, such as hormones and previous surgery, can certainly affect your fertility. So this is an interesting slide, as we've mentioned, that women are born with all the eggs that they will have, and when they become fertile through adolescence, that number has already started to reduce a lot. The quality of the egg and the number of eggs is reducing with age. So here you can see that it's relatively stable up until 30 years of age, and then starts to slowly reduce, with an increase in that reduction after 35 and then after 40 and 45 years of age. So that's where, unfortunately, it's a bit unfair, but age has a big factor on fertility. We know that chromosomal conditions increase with age, and that's why the risk of miscarriage is a bit higher when women are older. Men are not out of the loop with this, so sperm quality does also reduce with age, and the risk of miscarriage is higher when the man is, or the sperm provider is, over 45 years of age, and some other medical conditions can be increased with older sperm. So looking at some fertility conditions that can have an impact on eggs and uterus, as we mentioned, polycystic ovarian syndrome has an impact on ovulation and how the egg is released. It can spontaneously happen, which is, as we said before, 60% of women with polycystic ovarian syndrome can still conceive spontaneously without any assistance. But sometimes that assistance is required with simple lifestyle factors or simple medications, and possibly IVF as well. If the fallopian tubes are blocked or damaged, then it makes it very difficult to conceive spontaneously, which is quite logical. And this is a reason for considering IVF treatment, so that those eggs can be fertilized in the laboratory and then put back into the uterus. Endometriosis is a challenging condition that there's a lot more awareness about, but we have known about this for some time and how this affects fertility. And as we mentioned before, The only symptom might be infertility rather than pain or heavy bleeding, which is also a common symptom with endometriosis. And adenomyosis is often not known about or not mentioned, but really this is important as well when it comes to heavy periods and painful periods, and something to consider. So looking at fertility conditions that can impact sperm. So we're looking at the concentration of the sperm, the motility of the sperm, and the appearance of the sperm. So a low sperm concentration can have an impact on spontaneous pregnancy. A man who has no sperm, which is called azoospermia, can be caused by a number of conditions. A vasectomy is an obvious one, but there's some medical conditions like cystic fibrosis or genetic conditions that can cause azoospermia. The block vas deferens, which is, as I mentioned, vasectomy, but cystic fibrosis can affect the vas deferens and cause blockage, even though sperm is still being produced in the testicle. So the working out of why someone's sperm count might be low or absent needs to be considered, and hopefully some treatment options can be then achieved by knowing what the underlying cause is. When should you seek help? This is where age is a big factor, particularly for women. If you have been trying for more than 12 months and you're under 35, or if you're over 35 and trying for 6 months, it would be worthwhile seeking help. Or if you are under 35 but have some other medical conditions that you think might affect your fertility, then seeking help sooner rather than later is usually a good idea. So a fertility health assessment would initially, in Australia, seeing your general practitioner, and they would start by doing some screening tests, some background checks, and looking at your history, and then possibly referral to a fertility specialist where some more detailed investigations can be done, and sometimes some further invasive tests to check things about your fertility can be done by your fertility specialists. So we're about trying to find out what might be the underlying cause for someone not to be getting pregnant, and then we can use these investigations to personalize treatment in the simplest and easiest possible way to help you achieve a pregnancy. So this fertility assessment is looking at all the parties involved in fertility, the history of all of those people. Like we've been talking about a healthy lifestyle. Balance is hard to find, but important to find balance, and knowing what to avoid completely, like smoking, alcohol, and illicit medications. Looking at the family history and the fertility history. Not always, but there will need to be some sort of physical examination or ultrasound scan. For a woman, that could be a pelvic examination, and an ultrasound scan for a man is assessing the penis and the testicles to try and determine why they might have a reduced sperm count. AMH is something that most people around the fertility know about or have heard about, and we've mentioned it a few times this evening. And while it's not a test for fertility, it does give us useful information about what the ovarian reserve is rather than the quality of the eggs, and it can help us plan treatment and dosing of medication if you are needing to do IVF. Your age is the best predictor of your ovarian reserve, but this AMH level can be helpful from a diagnostic point of view and also treating into the future. So a summary of what we've talked about. seeking help early rather than later, but particularly if you've been trying for more than 12 months, looking at your history, your fertility history, your medical history, your surgical history, so that we can try and find a cause and know how best to help you achieve a pregnancy, and doing a number of these investigations to help put that all together. So if you have concerns, the first step would be to see your local GP for an assessment and possible referral to a fertility specialist. Initially, we will go through your history and tests and require any additional tests that might be needed. And Medicare does help with consultations and also helps with fertility treatment, but there is usually some out-of-pocket costs because the Medicare coverage doesn't just really cover the cost of what it is to deliver this service, so there will be some out-of-pocket. So Monash IVF is a well-known fertility provider that has been doing this for some time and has lots of experience. We are able to provide hopefully a continual service throughout your fertility process, from assessing and seeing a fertility specialist who works with Monash IVF, and that's the lab that really does all the amazing work where the scientists are able to put this material together to create an embryo, which can then be cared for and hopefully transferred with a pregnancy in the future. Thank you. And I think that we've probably come to the end of the presentations, and I'll send it back to the host so that we can go on to the next part of this program, which I think is Julie.
Yeah, thank you, Kelvin. And I'd like to thank you all for all the specialists for sharing their wonderful knowledge and experience. And if anyone's wanting to book in with them and they've missed the QR code or contact information, just reach out to us and we will get back to you with those details. And just before we go on to the Q&A, I just wanted to tell you briefly about the Ready Set Baby program. It's a free program delivering fertility guidance straight to your inbox over a 15-day period. It's a wealth of content, and you'll hear from so many different fertility specialists, experts in optimizing your mind, body, and fertility. And I'd recommend to anyone interested in planning for pregnancy, you can learn more by also scanning the QR code for this program. But you'll also get a free cookbook if you haven't received one already for doing this webinar. So highly recommend this program to you. All right, so let's go on to Q&A. So we've had lots of questions come in, so let's see how many we can get through, and hopefully we can answer as many as possible. So let's look at the first one. Right, so the first one is for Dr. Anju. If cycles are irregular, how can someone identify their fertile window?
When cycles are irregular, the first thing to consider is whether you are ovulating or not. There are certain kits available. I mean, there are natural ways of identifying ovulation, such as the cervical mucus, checking your basal body temperature. But these are usually retrospective tests. Like if there is rise and then drop in the basal body temperature, it just means that you have ovulated. But the LH predictor kits are pretty good in terms of predicting ovulation. But my understanding is that usually if the cycles are irregular or delayed, you're probably not ovulating. So it is better to see a specialist, get your progesterone level checked, and at frequent intervals, like at day 21 or day 26, to assess whether you're actually ovulating. And that would be the advice I would give.
Great, thank you. And next question for Dr. Jenny. Does letrozole cycle affects the ovarian cyst, and is it advisable to go for letrozole or any other ovulation induction medicine while having an ovarian cyst, I think it's meant to say?
Okay, I'm going to give you a couple of answers to that. So letrozole is a tablet that we can use to induce ovulation, and we would commonly use that in women with polycystic ovaries, where there's lots of tiny little cysts. But I think the question relates to a dominant cyst. Look, generally, if a cyst is less than 6 centimeters, it will probably resolve spontaneously. A persistent cyst may need further investigation. If the cyst was 2 or 3 centimeters, you could actually, as long as it wasn't producing hormones, so we check the baseline estrogen. So when a woman is day 2 or day 3, we want to see it less than 200. If the cyst is not making hormones, it's not going to have an impact on the process of ovulation. And I would just continue. But a larger cyst, you might end up with a higher baseline estrogen, and I wouldn't do ovulation induction in that case. I would either wait for that cyst to resolve over the course of a cycle, which may very well happen. The other thing you can do we sometimes give a trigger and we say we trigger it off, but you've probably got to be a bit later into the cycle. There are other agents used to do ovulation induction, other oral agents. Another one would be Clomid, commonly used again for polycystic ovaries. And it's a completely reasonable, very non-interventional option in a young woman. I wouldn't do it as a first-line treatment in a woman over the age of 35. I would say we get a good pregnancy rate in women where the underlying cause is polycystic ovaries, the sperm is normal, and they're young, in their 20s, or they're going to say up to the age of 32.
Thank you, Jenny. And for Dr. Kelvin, what percentage of infertility cases involve male factors?
Good question. What I've found interesting over the last years of doing this is that often the woman will come thinking that they're the problem, and it's all female related, and the male factor is quite common. So 50% would be a good starting point because it takes two, but it is a very common factor that there's a sperm consideration to the infertility. And it can be surprising that it might be unexpected until you do the semen analysis and check some things that you might not realize that there's a male factor as well. And it's just unfortunately presumed as being a female factor until proven otherwise, sort of thing.
Yeah, great. Thank you. And Dr. Anju, if you're having mucus for 3 days, how do you know when you've ovulated? How long after the mucus appears is ovulation?
I think it's a change in character of the mucus. I have to go back to my medical school days to remember the mucus thing, but I think it's a change in the character of the mucus that you understand that it's ovulation. Remind me, Jenny, it goes from like
I'm
thin
going
to
to say that it's like I always say egg white mucus it's like really sticky, and that's the really fertile mucus. And I mean that really disappears when a woman ovulates, and I mean sometimes then it just becomes physiological discharge. I suppose
discharge. That's right.
Yeah.
Great, thank you. And Dr. Jenny, what level of TSH do you recommend to have the best options for ICSI having thyroidism?
Yeah, okay. So the question,
hypothyroidism.
I'm going to change the question to say, what is the ideal TSH to optimize fertility?
Yeah, great.
So that'd probably be the question.
Yeah.
Around 2.3.
Okay.
But if like you can't always get it around that, and you would accept, I think you would accept anything up to low 3s really. The higher it is, that implies that the thyroid is underactive and the TSH is having to drive it. And so if it was like low 3s and you tried to replace that, you might end up with an over-replaced thyroid. If I had any questions, I always ring my very close endocrinological colleague and I ask her. I think the American Endocrine Society says 2.3, but I would accept possibly up to 3, low 3, something like that, as long as the T4 and T3 are, within the normal range.
Okay, great. Thank you. And Dr. Kelvin, how can an infectious disease affect fertility if it's well controlled?
I guess it depends on the particular type of infectious disease. So we know that with pelvic infections like chlamydia and gonorrhea, if they're picked up early, treated early, and a test for cure of that infection, then they're less likely to cause permanent damage or ongoing pain. Other types of more chronic infectious diseases need to be considered. It doesn't mean you can't do fertility things, but keeping them, I'm thinking more like the hepatitises or, HIV and those sorts of things. You want them as under control as possible. So it's that getting that balance and having them not overwhelm the body that would affect fertility, and also taking into consideration the transmission to a pregnancy. If that's the two different types of infectious diseases that you would be looking at considering.
Great. Does anyone want to answer this question, which are, I have heard conflicting messages regarding semaglutide and other GLP-1 receptor agonist medicine. When weight is considered a factor for fertility, can GLP-1 treatments increase the chances of success? Or does it cause an increase in miscarriage? Is the miscarriage chance minor and due to other health factors like correlation versus causation or reduced nutrition? What are your opinions? And thank you for your time.
I can answer this one.
Great.
I'll just break down the question into the different segments. I'm in big favor of using GLP-1s for weight loss for women coming with infertility, particularly in the subgroup of PCOS and insulin resistance, because I think it really works wonders. I don't believe that there's any research that it increases risk of miscarriages. There is recommendations that women should not fall pregnant while they're on GLP-1s, and there is a recommended 2-month washout period. There is concerns, especially in animal studies, that if women do fall pregnant when they are on GLP-1s, there might be some epigenetic changes on the sperm and the eggs, and that we don't have long-term data on how that would go with the unborn children. So the current recommendation is to have a 2-month washout of the GLP-1s and then to try to conceive. And that's the recommendation I'm following with my patients. But definitely there is a significant improvement in the fertility outcome and also the pregnancy outcome. So our aim is not just to fall pregnant, but it is important to take the baby home and have a healthy, safe pregnancy. So I find that I don't actually tend to see my patients again after 12 months often because they've lost that much weight, naturally pregnant, and then have a healthy pregnancy. That's what I'm seeing in my practice.
Great, thank you. Dr. Kelvin, how much do polyps affect embryo implantation?
So it depends really, I think, on the size of the polyp and what the endometrium is like. So often women will have an ultrasound as part of their workup for fertility treatment, and small polyps will be seen, 5 millimeters under 1 centimeter, and it's hard to know how much of an effect that they would have on the pregnancy. Probably not too much, but if it's a larger polyp or a fibroid coming into the actual cavity of the uterus, then that patient might need to have a hysteroscopy to have a look, with the aim at checking whether that polyp actually is there or not, and if it is, removing that polyp and having it tested. They're unlikely to be of concern from a malignancy perspective, but it would be important to remove large polyps and check the cavity before a pregnancy.
Great. This is a question I hear all the time, so if anyone wants to answer it, because I think a lot of patients aren't aware of the amount of time melatonin is prescribed, but is it okay to take melatonin during IVF cycles to help lower stress levels?
Absolutely okay.
Yeah, and I would say yes too.
Yeah. Yes.
Yep.
Great. Easy done, that one. All right. Let's have a look. This is for any of you. Are at-home insemination kits effective?
Yes.
Sorry, say that again.
Are at-home insemination kits effective?
Yes.
Yeah,
I've had
they are.
patients who've been pregnant using them at home. Sometimes I give them a few little tips and just to try and, make sure they get it into the right spot. But yeah.
Great.
I've never seen what they look like, but I've definitely seen patients get pregnant with them.
Yeah. Good. All right. There we go. So this is for any of you. What are your thoughts on having an endometrioma in an ovary of 3 centimetres? How does it impact, and what should be the next steps for conception?
Look, I can answer that.
Thank you.
You have to look at the whole woman. You have to look at her age, her ovarian reserve. Is this in fact an endometrioma? Is it a persistent cyst or is it a hemorrhagic cyst? Let's assume it's a 3 centimeter endometrioma. Does she have other signs of endometriosis? Has she tried to get pregnant naturally? It's all these things. If she's got a low IMH, you are not going to jump in there and remove it as the first thing you do because of the risk of loss of normal ovarian tissue. I always say that it's not a simple yes or no answer, and so you're sort of getting that from my answer as well. Everyone who walks into my room has I always say they've got different expectations. Some women will walk in and say, under no circumstances do I want IVF. I want an operation. And in that circumstance, if this woman's having problems falling pregnant, I would talk to her about doing an operative laparoscopy for endometriosis. But I stress you need to be respectful of normal ovarian tissue, and there is definitely a way to do it to preserve normal ovarian tissue. And the importance of removing all the extra ovarian disease as well. But on the other hand, the woman might come in and say, under no circumstances do I want an operation, I'd like to do IVF. And you can stimulate ovaries with a 3 centimeter endometrioma. You'd want to give antibiotics. You want to try and avoid that endometrioma as best as you can when you're doing an egg collection. But I think anything you do, if what you do doesn't work, always come back, reassess and think, we might need to take a different direction. If IVF doesn't work, they might need an operation. If a laparoscopy doesn't work, they might need IVF. That's my answer to that question.
Great. Thanks, Jenny. Dr. Anju, is it normal for basal body temperature to rise after 3 days?
Yes.
That's it. Excellent. Good. All right. You can be comforted by that. All right. Dr. Jenny, what counts as moderate exercise? And if you have coffee before noon and are not impacted by it, for example, anxiety or sleep, is it okay to have more than 200 milligrams?
All right, moderate exercise. There is evidence that if you do more than 3 1-hour aerobic sessions per week, like women who exercise every day 4 or 5 times a week, that can have a negative impact on ovarian function. Now, that's going to have that impact will be seen sooner in a woman who's underweight because she's already got that impact of a low BMI on her ovarian function. So that's the answer to my first question. In a woman who's exercising every day, that is absolutely having a negative impact on her ovarian function. And that is a very difficult conversation to have, to say you need to exercise less to be able to get pregnant. I'm not asking you to cut out exercise for the rest of your life. I'm just saying this particular moment in time when we've got a window of opportunity to get you pregnant. So that's the first one. And the second question was, what was the second part of that?
Coffee.
Coffee. Thank you.
You know what? I don't know how much 200 milligrams is. I normally just say like 2 cups, 2 shots of coffee. I think you can have up to 4 a day, but I would think that that has quite an impact on sleep. I think you can have 4 a day is my answer to that, but I generally say to women, try to keep it at 2 a day.
I think research shows 2, doesn't it?
I also advise 2 a day.
Is it a double shot or a triple shot? If you're in
No,
Melbourne,
a single shot.
Single shot, 2 coffee a day is
what
is the general advice.
It is,
with
yeah,
research
totally.
backed up.
So we're saying that there's 100 milligrams of caffeine in 1 shot. Is that what it is?
I believe so.
All
is
right.
that right?
I say 2. I say 2 shots. There you go.
I think there's a message that says a shot of espresso is about 70 milligram.
Okay. And I think it also depends how
All right, so
affected.
3 shots.
I always
say
to patients, if caffeine makes you feel anxious, then I think your body's telling you not to drink it anyway. So anyway, so
I have a friend who is a surgeon, and he drinks decaf all the time now because when he was drinking caffeinated,
he was shaking.
But not only shaking from a surgery point of view, it's just making him grumpy and irritated.
Right.
And
I can't drink more than one.
Drinking decaf is fine. So
yeah. I shake after one, but some people can tolerate it really well.
Well, that's a big topic tonight, isn't it? Caffeine. All right. This is for anyone, so it's interesting. So HIV effects on fertility when viral loads are undetectable.
I'm going to say no impact.
No impact.
Okay, great.
Asking the wrong doctors, but I think if the viral loads are unimpacted and they're healthy and well, the risk of transmission is low as well, I would
think. That's it. I look at it from the sperm donor point of view as well. Like if we have, couples where we use known sperm donors as well who have undetectable viral load, we're happy to use them. So I would say it's unimpacted.
Great. All right. Anyone want to answer this one? If you have higher muscle mass, is there a recommended fat percentage instead of BMI, or is it just based on quantity of body due to the dilution of hormones, etc.?
No, we only ever talk about BMI. Do you agree with that?
We do, but I believe that it's not the best tool because people can have excess muscle mass, which is a good thing to have, but then that raises the BMI. And then if he does talk about muscle mass, which is also not accurate because there's no better way of measuring them. So it's not perfect, the BMI, but that's what we use because that's what we have.
It's the best we have.
That's right.
It's the best we have, unfortunately.
Come back to balance, come back to balance. Yeah. So these are tools that we use, but they're not perfect tools. So we have to look at the big picture. Yeah.
I think it's great that it's answered in some shape or form, though, because I've had patients that are really quite well-known athletes whose BMIs are high, and it can really upset people when they're trying to get pregnant and their BMI. Yeah. Anyway. All right. What are your thoughts on, this is for Jenny, what are your thoughts on letrozole effects on 3 centimetre endometrioma with almost no endometriosis, pain or signs?
Okay, that situation is probably not going to exist because they've said that there's no endometriosis. The only way you're going to diagnose endometriosis is by looking inside, doing a laparoscopy. And if you're going to do that, you're going to treat that endometrioma, like you're not going to leave it. The question says that the endometriosis is confined to the ovary, and the only way you know that is by doing a laparoscopy. So that situation is not going to exist. Like, there's no way you do a laparoscopy and leave the endometriosis and come out again. You would treat it all in that one sitting. So perhaps I'll change that question just to say, would you give letrozole if there's a 3 centimeter endometrioma? I'm going to give the same answer that I gave before, with the woman who's got a 3 centimeter endometrioma, and do you do a laparoscopy or do you do IVF? I'm going to say, do you do fertility treatment or do you do a laparoscopy? It's actually the same answer. You're only going to give letrozole. I would only give it 3 cycles, and I don't think you're going to see a significant increase in the size of that endometrioma over 3 cycles. But the question is it going to work or not? That's probably going to be an age-related thing. Younger women will get pregnant, older women might not.
Okay. Look, I think we've got time for just a couple more questions. So is there an age cutoff that the clinic will see you? So anyone want to answer that, and why?
Yeah, that's fairly black and white. There's no age cutoff. I will always talk to someone, no matter what their age is. But the recommendation is not to use your own fresh eggs in an IVF cycle after your 46th birthday, and not to have an embryo transfer with either donor eggs or your own frozen eggs or frozen embryo after your 53rd birthday.
Okay. Excellent. And just one more for any of you that would like to take it. 4th cycle now after endo excision, and still haven't fallen pregnant. Should we be considering IVF, or should we just give it more time? What is the success ratio of IVF?
I can answer that.
Thank you.
I think I'll break that down. Actually, it depends a lot upon how old the patient is, and if there are other factors, and there's how severe the endo was. There's lots of recommendations now that minimal to mild endometriosis excision actually improves natural fertility for couples. So if it is 4th natural conception, I'm guessing, with ovulation and no other tubal factors, I still feel, and if you're fairly young, like under 30, I would still give it another couple more cycles, maybe.
I say total of 6.
Yeah, a total of 6 cycles. And I tend to also sometimes do the EFI, the Endometriosis Fertility Index, as well to help guide that. But 6 cycles, and if not pregnant, at least start preparing for IVF, if not already jumping into IVF. And also then again, based on your reserve, if the AMH is good, you still have a little bit more time. But if you're 35 or around 34, 35, you've had 4 to 5 cycles, ovulatory cycles, and you are not pregnant, I'd be thinking about IVF. And again, the next question, the success ratio of IVF, that also is very much age dependent, and what else is going on. With endometriosis, we know that the success rates is a little bit lower than it is with your peers otherwise.
Great. Well, thank you, wonderful team. I'm afraid, everyone, that's all we've got time for. So if your questions weren't answered, please do remember to scan that QR code for a complimentary nurse chat. You'll get lots of information from that. And thank you for attending. And I'm sure that all the doctors on here would agree that we wish you all the very best on your fertility journey. So thank you for all your fantastic knowledge and information, doctors.
Bye-bye.
Bye-bye.